Start. I am Tara Haelle, and I welcome you to today's webinar, the Maternal Tdap vaccine, the evidence behind it, and how to tell that story. I'm the Health Beat leader for the Association of Healthcare Journalists, and AHCJ is partnering with the University of Minnesota's Center for Infectious Disease Research and Policy, known as CIDRAP, and their Vaccine Integrity Project, as well as the Evidence Collective, to bring you this webinar. The Association of Healthcare Journalists is the largest organization of healthcare journalists in the U.S., and AHCJ, CIDRAP, and the Vaccine Integrity Project and Evidence Collective are all independent organizations that do not receive funding from pharmaceutical industry. Today, we are discussing a report that's brand new from the Vaccine Project and the Evidence Collective, the Vaccine Integrity Project, on the safety and effectiveness of the Tdap vaccine. That's the vaccine that protects against pertussis, diphtheria, and tetanus, diphtheria, and pertussis, excuse me. And this immunization is recommended during pregnancy from the American College of Obstetricians and Gynecologists, the American Academy of Pediatrics, the Society for Maternal Fetal Medicine, and many other medical organizations. So we'll be discussing the data, but we're also going to discuss how to effectively communicate that data to your audiences. Joining us today will be Dr. Rochelle Walensky, a professor of medicine at Harvard Medical School and medical affairs advisor for the Vaccine Integrity Project and former CDC director. Dr. Emily Senarth, a consultant researcher for the Evidence Foundation and the Evidence and epidemiologist. Goodness gracious, excuse me. And Dr. Bertha Hidalgo, an associate professor of epidemiology at the University of Alabama and a steering committee member of the Evidence Collective, and Elizabeth Marnick, executive director of the Evidence Collective and a science communicator and immunologist. A reminder to anyone who has been on this before and new to those of you who are new, all attendees are muted during this webinar, and while the speakers are presenting, you can ask questions by typing them into the Q&A space where the question mark is at the bottom of your Zoom. I will direct the questions to our guests once our Q&A begins. Also, a reminder that this is on the record and a recording of this webinar will be publicly available later today or tomorrow. All right, Rochelle is going to start us off with an overview of the report's evidence, and then Emily will be joining us. Let's get started. Thank you, ladies.
Thank you, Tara, and thanks to AHCJ for hosting this webinar. I will get started. Next slide, please. First, just a little brief background on the Vaccine Integrity Project. Back in May of 2025, actually, we started listening sessions with over 60 individuals and organizations to understand what kind of vaccine and vaccine activities could be performed outside of the U.S. government. The Vaccine Integrity Project was created to support the independent, transparent, evidence-based evaluation of vaccines and vaccine policy. This was a space we thought we could actually offer some support. We at the Vaccine Integrity Project conducted our first evidence review in the last fall for the 25-26 respiratory virus season, doing a review of influenza, COVID, RSV immunizations that we subsequently published in the New England Journal of Medicine. And our review included safety, effectiveness, immunogenicity, and we always do an assessment of the quality and limitations of the evidence base. We are now conducting in this review the evidence review for Tdap that was conducted at the request of the American College of Obstetrician and Gynecologists. It has been 6 years since that last systematic review, and that is the review we are bringing you today. The work of the Vaccine Integrity Project is funded by the Alhambra. It's a foundation that kickstarted this effort, as well as this specific review that was funded by the Rockefeller Foundation. Next slide, please. The Vaccine Integrity Project focuses on 3 areas: summarizing and disseminating scientific evidence, as is the context here, engaging with healthcare providers, the public health community, and medical societies. We conduct these comprehensive systematic reviews, to inform vaccine recommendations made by societies. We also respond to misleading and inaccurate claims where we monitor and address inaccurate vaccine and public health related information in real time. And then we foster collaboration and visibility. The scale and complexity of these challenges demand ongoing collaboration across sectors and a coordinated response in the vaccine ecosystem. Next slide, please. So just briefly on pertussis and why we are here today. Pertussis is the Bordetella pertussis is the pathogen that causes what is well known as whooping cough. Early symptoms of whooping cough are a runny nose, mild cough, and low-grade fevers, but subsequently later symptoms, you get a violent cough, coughing fits, that's the commonly known as whoop, and difficulty breathing. In 2025, there were over 28,000 known cases of whooping cough and 16 deaths. This disease is particularly severe in infants. 10 of last year's deaths occurred in infants, and about a third of infants less than a year old require hospitalization when they get whooping cough. The challenge is that especially these infants that are less than a year old, these babies are not yet able to get the vaccine. And the way that we protect babies from pertussis is by vaccinating mom during pregnancy, recommended between 27 and 36 weeks. This gives passive immunity to the baby and protects the baby until the baby is able to be vaccinated at the age of 2 to 4 months. And so it is not just recommended that that mom get vaccinated, that the pregnant person get vaccinated the first time, but during every subsequent pregnancy to protect each baby. Next slide. So the first time vaccination was recommended in pregnancy, according to the CDC's Advisory Committee on Immunization Practices, was in 2012. The evidence review was done for that recommendation prior to 2012, and that evidence was updated in 2019 in an evidence review that was published in the MMWR in 2020, and again re-upped the recommendation that during pregnancy, between the ages of 27 and 36 weeks during each pregnancy, there should be vaccination. The potential benefits of this are to reduce pertussis morbidity and mortality among infants prior to vaccination. And the review actually looked at any potential harms, any adverse events associated with vaccination, either during pregnancy or subsequently to baby. The data on vaccination during pregnancy, as you can imagine, are sparse. This is a special population with rare events, and safety monitoring is ongoing. Next slide, please. So our research questions here, and then I will pass it off to Emily, are there any new data over the last 6 years that can help inform any updated recommendations we might have with regard to safety during pregnancy? And are there any new data published in the last 6 years to look at the effectiveness of Tdap during pregnancy? As we know, organizations are considering updating their recommendations. So we wanted to make sure that they had a comprehensive review of the evidence. And with that, I will pass it to you, Emily.
Okay, so in order to answer these questions, the Vaccine Integrity Project commissioned a systematic evidence review. We identified 29 studies that had been addressed and analyzed in previous systematic reviews. So that's from 2011 to 2017, kind of informing those first iterations of that CDC recommendation. And then from 2018 all the way through March of this year, we identified another 14,000 studies. So once we screened those against some pre-specified eligibility criteria to make sure they were relevant to our research question, we ended up looking at 236 full text articles and landed with 62 new studies eligible. So that included randomized trials as well as non-randomized or observational studies. When we combined the 62 and the 29 from the previous reviews, we ended up with 91 total studies. So 12 randomized studies of Tdap during pregnancy and 79 non-randomized studies. So these looked at observational data from electronic health records and insurance claims databases, as well as cohort studies of specific populations. So we looked at pre-specified safety outcomes that in consultation with some subject matter experts, were identified as being potentially really important to people who are making the decision about whether or not to be vaccinated during pregnancy. So we looked for data on stillbirth, preterm birth, preeclampsia and eclampsia, chorioamnionitis, placental conditions including hematoma and retained placenta, as well as gestational diabetes, and then a broad spectrum of adverse events during pregnancy and also any severe vaccine reactions. So these include premature contractions, premature labor, any sort of hemorrhage. And across all of these different outcomes, once we pooled the evidence that was available from the RCTs and the non-randomized studies, we found no meaningful increase in adverse events during pregnancy with Tdap compared to no Tdap vaccination. So another way to think about this is that the rates of these events were similar during pregnancies without vaccination and those with. I'm going to talk a little bit more about some of the specific concerns around limitations of the evidence at the end, so I will come back to that. We also looked for vaccine safety outcomes that might manifest or occur during early infancy. So these included neonatal mortality, congenital anomalies, NICU admission, neonatal sepsis, growth restriction, and low birth weight. And again, across the totality of evidence for each outcome, we saw no meaningful increase in the adverse outcomes during infancy when those infants were exposed to Tdap vaccination during pregnancy compared to infants who were not. And again, we'll come back to discuss some limitations there. For effectiveness, we looked at both clinical effectiveness and immunogenicity data. For the clinical effectiveness outcomes, we looked for data on pertussis infection in infants, serious complications in infants, and also pertussis-related mortality in infants. So in non-randomized studies, including over 2 million infant participants, we found that Tdap during pregnancy likely reduces the risk of infection, as well as the risk of serious complications as measured by hospitalization and emergency department visits. Pertussis-related mortality was a little bit more difficult to measure just because this is a very, very rare outcome. So our data suggested decreased risk, but this is really this effect has a lot to do with the background rates of disease and this sort of circulating pertussis in the population. So we would expect that in areas where there's a higher disease prevalence, we might see more of a pronounced decrease in risk of mortality. The immunogenicity data were all consistent with these results. So we saw increased antibody levels in blood and cord blood at birth, as well as in that first 2 months of life before the infants started their primary Tdap vaccine series. So these findings are consistent and sort of underline that biological mechanism for protection. Okay, challenges and limitations across our body of evidence. One thing that we navigated as we were looking at those 92 eligible studies is that a lot of the data sources for those publications were kind of similar or overlapping. So the surveillance systems such as VAERS, the Vaccine Safety Data Link Network, and the U.S. Emerging Infection Program Network, these all are massive administrative data sets that a lot of different researchers were drawing from for their publications on Tdap safety and effectiveness. So we were very careful about making sure that we were, insofar as possible, only counting each participant once for each outcome. However, we can't totally exclude the possibility that in some situations, there was duplication of a small number of participants across multiple outcomes. So that's a caveat to be aware of. Also, what we're looking at are inherently very rare events in terms of both the vaccine side effects and any serious complications or fatalities related to pertussis. So This means that you need a really large number of participants to reliably detect and measure what the rates of these events are. And even in studies with millions of participants, it was challenging to get sufficiently precise estimates. However, despite these challenges, we would expect that with this volume of data, a signal around any safety issues would emerge. And finally, there are just some methodological limitations to be aware of when you're looking at observational data around the difficulty in controlling for all of the possible confounding variables. And in particular, the healthy vacciné effect is a consistent challenge just in making sure that our population who's getting vaccinated is in fact the same kind of background characteristics as the population who is not. So we had some issues with potential residual confounding, as well as follow-up data on some of these administrative data sets where we didn't have complete information for all of the participants. That being said, our findings are consistent with previous systematic reviews and guidelines in this area in demonstrating that Tdap vaccination during pregnancy provides important protection to infants, particularly with regard to the pertussis infection. We didn't see any evidence of a meaningful increase in serious adverse events or those negative outcomes in pregnancy and infancy. And again, just underlining the importance of ongoing monitoring and research in this population so that we can continue to add to our body of evidence and have more certainty going forward. So with that, I think that's our last slide. And I will turn it over.
All righty. Thank you very much, guys. Really appreciate hearing all the details of that report. We're now going to move on to Bertha and Liz, who are going to talk about the most effective way to communicate this information, especially in today's environment where vaccines and vaccines during pregnancy may be a little bit more polarizing.
Yeah, well, thank you so much for having us, and thank you guys for presenting that great data. Oftentimes, though, right, the hard part is once we have data like this, what happens after the data. So I'm going to introduce a little bit first what we do at the Evidence Collective. So we are a collective of over 30 subject matter experts. So I have a PhD in immunology, we have scientists, we have clinicians, we have public health officials, and all of us also are actively communicating science, primarily on social media, but also through a diverse modality of other ways of disseminating information. Combined, we have reached over 11 billion people last year, and combined, we have over 10 million followers. So we really are focused on kind of three areas when we think about how we can communicate evidence in this moment. We think about increasing speed. Misinformation, false information goes really fast. And when we're all working as individuals trying to battle it, it feels like we're bailing out a sinking ship. So by banding together, we can really help increase the speed at which we address and deal with potential false information as it spreads. And that's also ensuring coordination. So one thing that, some people do really well is getting the same talking points out on social media. When I scroll social media, I see all sorts of people saying, the Tdap vaccine is unsafe for very specific reasons. Or I see people saying, this vaccine causes SIDS, and it's a mom influencer, and it's a farmer, and it's all these different people saying the same thing. And we typically don't see the same type of, coordinated messaging from those of us who value science and evidence-based information. So we're working to help create that surround sound approach and coordination. And then we also are doing a lot of work to break echo chambers. I know the people who follow me on social media, the people who follow Bertha, they probably already, like science and going to us for help navigating it, but they're not necessarily the people who are in most of need of this information. So we're working to figure out how can we actually work with other groups of people and equip them to talk about these. So we are doing things working with mom influencers, working with faith leaders across the country, working with other groups of people who are trusted in their communities, but don't necessarily feel empowered to, talk about these types of conversations related to vaccines, science, or public health more generally. And all of our communication, though, is very much grounded in empathy. We understand that this is a very, challenging time for people. Most people are trying to make the best decision they can for their family. And we really empathize with that. And we make sure that our communication, while being, accurate, is also grounded in that shared understanding. So I want to talk a little bit to set the stage for how we think at the Evidence Collective about communicating data like this Tdap information, is to think about pregnancy as being this window of persuasion. I know when I was pregnant with my first child, before I was pregnant, I never saw anything about vaccines or sleep or formula on my social media. But as soon as I was pregnant, it was almost as soon as I had that positive test, all of a sudden social media started feeding me all of this misinformation related to vaccines and all of these other areas. And pregnancy is often the first time people are, exposed to the kinds of decisions they're going to have to make for themselves and their children moving forward. And this can be hard because this tends to be where they encounter all of this vaccine misinformation. These are just a few screenshots. I could have pulled hundreds more, looking specifically at the kinds of misinformation we're seeing spreading on social media related specifically to the DTaP vaccine and pregnancy. And oftentimes, when we look at these types of narratives, we see that they're weaponizing stories as a way of spreading fear. And that can be really, hard for somebody who is pregnant, because if you think about it, pregnancy is also a period of time of intense scrutiny. When you're pregnant, you're told you can't eat this, you can't do this. And everyone, you feel like, is looking exactly at what you do. And then if something goes wrong, right, you then have to sit with the weight of that potential guilt, whether or not it's justified. It is just the way that society is, the way that we kind of have cultivated this. So every decision that you do in pregnancy feels very high stakes, very high risk. And that is combined with the fact that the world has a lot of opinions. I know when I was pregnant, people told me, don't keep running, it's dangerous. And then I had other people tell me, oh no, keep running until the end of pregnancy because it will go make your pregnancy easier, right? So people, when they're pregnant, are confronted with all of this conflicting information at a time where it's really, hard to navigate all of this information. So whenever we think about communicating data related to, maternal vaccination, we have to really recognize the whole surround sound system that these individuals are steeped in as they're thinking about whether or not they're going to make this type of decision. And even, when we look at what is recommended in a doctor's office, sometimes, even medical providers can give mixed messaging, guidelines change. People aren't sure what the actual recommendation is. Sometimes, the why isn't actually explained in that medical appointment. So people are, not sure how to navigate that. So it can be a very confusing time. So one of the things that we think about at the Evidence Collective is this, combination of debunking versus something I'm going to talk about in a second called pre-bunking. In debunking, we're always kind of we're being reactive. A myth appears, it starts circulating on social media. All of us then try to say, here's all the reasons why this is wrong. The problem with that is there's a lot of data from social science that the more somebody sees misinformation, the more likely they are to believe it's true, even if it's not. And that's one of the things that's really dangerous in this moment in time, is that so much false information related to Tdap, maternal vaccination in general, vaccines in general, are spreading on social media. So even, somebody who maybe wouldn't have questioned vaccines before can start to feel a little bit like maybe I'm wrong, right? Maybe I should be questioning this because all these other moms are questioning this. So by the time we're correcting false information, we're often behind, right? People have already seen it a lot. They already are inclined to believe it. And that's why one of the things that we do at the Evidence Collective is thinking about how can we prepare people ahead of time before they might start to see this type of false information. This is also known as the inoculation theory of misinformation, or pre-bunking, as a lot of us call it. And this helps people think about it helps those of us communicating think about what kinds of things might start circulating at different times. And I think pregnancy is actually a really great example of this. So if we can start intervening early, let's say when somebody is trying to conceive or targeting people before they're pregnant in the first place, we can help prepare them ahead of time for the false information they're likely going to start to see as soon as they get that positive pregnancy test, as soon as they start, Googling cost of diapers and all of those things. So because pregnancy is such an interesting period of making these decisions and having to grapple with these choices, this is also a really great period of time for thinking about how can we start presenting this information about Tdap and other maternal vaccinations and vaccinations for their child ahead of time before maybe they're inundated with this false information. And one really great way to do this is I mentioned how, bad actors tend to weaponize stories. We on the side of, science tend to rely mostly on data without always necessarily bringing in stories. I wanted to flag a really great resource from Vaccinate Your Family. They have great stories about whooping cough and people who have been impacted by it. And this is a great complement to the data because you can include these types of stories along with the data to really help make that data land better. I'm going to now hand off to Bertha, who's going to go through some other more concrete examples.
Thank you so much, Liz. And also, before I launch into this section of the presentation, thank you all for being here and your willingness to learn more about all of this. As you work to put these stories together and share the findings from this fantastic results that were shared earlier, we want to start by also sharing some of the experience that we've gained through our science communication. One of our tech members, Dr. Kristen Pethagani of You Can Know Things, put this really nice table together of words and phrases that are often commonly used that are very harmless. Things like works, effective, immunity, prevents, and safe. And it's interesting, we often forget what it's like to not know something. As health journalists, you've probably gained a great deal of knowledge about health topics. And for those of us that are medically or scientifically trained in individual areas, we forget what it's like to hear information for the first time, right? And so when you say something works, like masks work, for example, what people may hear is this will fully stop the bad thing from happening. That's one interpretation. And what we should be talking about instead are things that are more nuanced, like it reduces risk, or it lowers the chance, or it makes severe outcomes more likely. And here we present alternatives to some of these words, and phrases that can be used instead. So for effective, you can think of phrases like highly protective or provide strong protection against. For immunity, immune response, or training the immune system. Preventing is another sort of very absolute word. And I'll caution that while humans are very binary thinkers, we like to really think in terms of yes, no, dichotomous outcomes, right? Alive, dead, right, wrong. Really, science is this very spectrum of considerations, but also of outcomes. And so here, this table really provides, I think, good alternatives to some of these words. Topics like vaccination require really intentional framing. This is not unique to vaccination. Other topics like maternal mortality and infant mortality also require that sensitivity. And what we want to communicate here is that in your writing, and we do this and try to do this very sensitively as well in our science communication on social media and other modalities, as Liz said, is that especially for topics related to pregnancy, but other topics as well, we want to avoid the blaming or shaming or the deficit framing. Use systems framings or opportunities instead. And on the next slide, what you'll see is a good example of the way in which we can do that. Why? Because oftentimes what we're focusing on with data is a disparity that exists. And how you write about disparities makes a difference. It could change whether audiences hear blame, or if they feel or hear that biology is to blame, or if there are systemic issues that are being ignored that they feel through their lived experience could also be the reason why disparities exist. And so risky framing can look like some people don't get the Tdap during pregnancy, the Tdap vaccine during pregnancy. And you might even replace some pregnant people with some subgroup of the population. What many audiences hear is that there's a lack of caring, that there's potentially poor decision making. And maybe the individual feels that, or maybe the reader thinks, oh, those people don't do X, Y, or Z. There's also an element of feeling individual responsibility. Liz talked about all of the guilt that pregnant people may feel. And so better framing may look like how we talk about vaccine uptake matters. And so focusing on individual behavior can really overlook these rules of healthcare systems, how you communicate about the Tdap vaccine in this case. Access. I want to highly encourage you to think about the groups that are being left behind. Who are we not thinking about when we're writing these pieces? Persons with accessibility issues who can't get to a place where they can be vaccinated. Persons who are non-English speaking or who have other literacy issues. Part of this entails also the trust that you build with your readers so they can better be informed and make decisions during pregnancy. And how do you do this without losing trust? Well, trust is hard to gain, right? And maybe you have built trust with your readership. But what we have found is that in our communication, oftentimes what we tend to lean into doing is that we hedge. We do a lot of hedging. In science, we talk about the uncertainty a lot. Additional studies are needed before conclusions can be drawn, for example. And what we've heard from comments and DMs and notes to our science communicators is, well, they don't know anything, or there's something they're not telling us because here's this sort of unknown and vague statement that was shared. And so maybe what we say instead is, hey, we know that pregnancy decisions can feel really stressful. In this case, the Tdap vaccine, the studies, including this report, has shown that millions of pregnancies across many countries show that the results and the benefits outweigh the risk. And more importantly, that this vaccine helps protect the baby from whooping cough during the first months of life when they're unable to be vaccinated themselves. So what does this mean for our communication? We lead with acknowledgement. We acknowledge that there is a lot of information out there and it can be really difficult to navigate. We also don't want to use language that implies that the person should have known or is behind in knowing in some form. Always, I think, write with the perspective that this is the very first time that people have heard this information. And now we have the ability to link to prior pieces. If there are prior pieces where you can, if you're limited on word count, have a really great explainer of some of the basics of the Tdap vaccine, for example, or whooping cough in general, or a really nice study about someone who had an adverse outcome because they didn't get vaccinated during pregnancy, for example. All of that can be linked to, and so it enables you to inform the piece with greater information without necessarily having to put it all in one place. We also encourage thinking about the Tdap vaccine as an opportunity for empowerment. One shot during pregnancy gives your baby protection from day one versus unvaccinated infants are at risk. And this really changes the way in which people receive the information. This number of vaccines is also really an interesting point. So your audience is going to have different concerns. They may be worried about the timing. They may be worried about side effects. They may be worried about the number. And the number of vaccines in particular is really salient because sometimes the Tdap vaccine is offered in combination with the influenza vaccine and the RSV vaccine. We know that some people have a lot of questions about babies in particular having all these vaccines introduced in what time, right? And so focus on what the vaccine does and what protection it provides. And be clear about the uncertainty. Give them the evidence that we have at hand at this time, including some of the limitations that you heard about earlier in the presentation. And then what we've learned also is that people trust people. Center on children and families, not institutions necessarily or science. You can use that as justifying information to complement the stories that you're going to tell about the Tdap vaccine and its effectiveness in pregnant people. Next slide, please. So I think then now actually we're at the conclusion of our presentation. We hope some of these recommendations are helpful to you as you move into your writing, and we'll hand it back to Tara for leading us into Q&A.
All right. Thank you very much, Liz. And excuse me, Bertha. One thing I wanted to, there's already one question in there, and I'm pleased while I'm talking, go ahead and put additional questions into the Q&A. And I'll be asking questions as well. I had one question. You mentioned avoid blaming, shaming, and deficit framing. I think most people know what blaming and shaming are. Could you explain a little bit about what deficit framing means, like what that is in this context?
Yeah, I think one of the things that we've learned over time is that there's a lot of scarcity of of information that is empowering to the person, and so deficit framing is sort of aligned with like victim blaming, if you will, a perspective where you don't acknowledge the specific challenges that are present for individuals that may prevent them from being able to do the thing that you want them to do. And so it's more about acknowledging the systems of access and structural barriers to being able to get vaccination or to even consider the information to begin with, right? Some people get all of their information primarily from social media, maybe others from their primary care physician. And if they don't have access for whatever reason to a primary care physician on a regular basis or to social media that informs them in an evidence and fact based in way, that's just those things are structural and not something that we should blame on the individual.
So just to clarify, the deficit is a knowledge deficit, right? Like framing it as though they're ignorant or they don't have enough information, or making it sound like it's their fault that they don't have access to the knowledge.
Correct. Or
Okay.
the people or the
Okay.
structures to gain that information. Yes.
Okay. That's what I thought. I'm mainly doing that. I think a lot of times when we get into public health communication, those of us who have been in it for a while are familiar with certain terms that people who are new to it may not. I'll
Sure.
just make a comment to some of the attendees. There's something called the deficit model of health communication that has been long used, and when I say long, I'm talking centuries, um, and has for long in decades been shown not to be effective, and that refers to the idea that that the way that you should help educate or communicate with people is to assume that they have a deficit of a certain knowledge, and therefore if you fill that deficit, if you give them the information, then poof, then that fixes behavior. And that is not how it works. If it was, we would all be slender, exercising, good sleeping people who don't smoke or drink, and that's not how life is. So I just wanted to clarify for people who were not familiar with that knowledge deficit model what that was.
Thank you.
The another question, and this one's sort of a housekeeping type question from one of our vaccine scientists who has joined us. If there is an error in the report, even if it's just like something minor, or there's a question about the report, who should they contact about that?
Yeah, thank you, Tara, and thanks for the question. First, I will say all of the data, you have a link in the chat, I believe, as to where the report lives. In that link, you have the full report as well as an executive summary. And at the bottom of that page, you can actually find all of the data. And so this was a sort of the primary analysis of the data and a link to every PubMed paper that is included. So, or every paper, a link to the PubMed site of every paper that is included. And that is really for full transparency. Within the report, there's also a link to the Prospero protocol, which is the reasons we did or did not include a paper within the report. So you may find your answer there as to if you are worried that a paper may or may not have gotten in. For example, all of the studies in the report were limited to vaccines that are used in the United States or have been used in the United States, for example. If it was an international study, for example, for a vaccine that's used elsewhere, we did not include it in that report. So you might have answers, and you might also have further questions and find another mistake. So if you do, at the bottom of the Vaccine Integrity Project website, there is a Contact Us box. That box will lead you to an email for Kevin Griffiths. You can send your email to him, and we will absolutely look into it. Thanks for that question.
Thank you for that. Another question, can panelists speak to the sequelae of pertussis when contracted in infancy? What are the potential short-term and long-term effects?
Yeah, maybe I'll take that one. So the first is sort of as we outlined earliest, and that is a risk of death. So there's actually quite a high risk of death associated with pertussis in infancy. As I mentioned, about 60% of the deaths from last year from pertussis were in babies under the age of 1. After that, you're talking prolonged hospitalizations and the sequelae of what happens if you either have anoxic brain injury from lack of oxygen to the brain or long-term sequelae from chronic lung injury. So that can be neurocognitive deficits, it can be epilepsy, it can be long-term lung injuries. So essentially, this is very much something we would want to prevent.
Can you get the Tdap with the flu, COVID, and or RSV vaccines? Those are so the flu vaccine, the COVID vaccine, and the RSV vaccine are also recommended during pregnancy, although I know the timing of the Tdap may be different from the timing of the RSV versus flu and COVID. Can you speak to I know this webinar is about the Tdap, but if people do a story that packages this with discussion of the other vaccines that are recommended during pregnancy, what's the best way to do that, basically, to communicate that, or safety of multiple vaccines, for example?
Maybe I'll start and then I'm going to pass it to Emily. And because I'm not, generally, as you can imagine, it's hard enough to find vaccine data, randomized clinical trials and whatnot on a single vaccine in pregnancy. If I can just speak to our experience as we looked into this for respiratory virus season, it is also hard to find co-administration studies. When those co-administration studies have been done, they have generally not shown an adverse impact of having these done together, having these vaccinations done together. But I'm going to assume, and Emily, please correct me if I'm wrong, that there were really no studies that looked at co-administration of these vaccines.
Yeah, that's correct. So we did not exclude any studies where people had received multiple vaccines during their pregnancy. So in, again, some of these administrative and health claims databases, it's represented among them are people who've received multiple vaccines. However, we don't have a way necessarily to stratify those data without doing some additional analysis. So at this point, we don't have kind of a separate estimate for co-administration of the vaccines, but they are represented within our broader data set of data that informed all of these conclusions.
Great. Another question about side effects. Some people may be having multiple pregnancies in a row where they, with a short period in between the pregnancies, and the Tdap is recommended in each pregnancy since the antibodies wane. Can you speak, were there any studies in there that looked at whether or not there was a higher risk of certain side effects with, like, let's say you had 3 children in a row with only a year or so in between each one, so you got that Tdap like every year and a half. Were there any studies that looked at multiple administration and whether there was a change in the risk of side effects?
Similar answer in that
Sorry.
we didn't find any studies that address this question directly. However, obviously in our data set, there are people who had multiple pregnancies. A lot of the studies actually adjusted for parity. So they kind of adjusted any impacts that happen from multiple pregnancies versus a singular pregnancy. But that would be a good area for future research, I think, is whether we would see a different effect.
And maybe I'll just say outside of the pregnancy context, we generally believe, and even within the pregnancy context, we generally believe that the adverse implications of not getting vaccinated when you don't know. So I'm thinking of tetanus in the emergency department. The answer is always, if you don't know if somebody's been vaccinated, you absolutely give it. And so if you were to sort of use that same schooling, certainly there could be more studies done, but that same schooling would apply. You absolutely should give it.
That makes me think of the precautionary principle, in that you'll hear some parents say, well, just to be safe, I don't want to get the vaccine because I'm worried about the side effects. And I think we can flip that on its head and say, well, just to be safe, I want to make sure that you don't get the disease. Like you can take that same precautionary principle and flip it. Maybe not quite in that exact wording, but I mean, conceptually. I want to move on to some of the communication strategies. You guys talked about the great resources at Vaccinate Your Family for stories. I'm going to highlight another one. Voices for Vaccines is a parent advocacy organization. They also have a lot of great stories. Obviously, storytelling is the backbone of a lot of what we do in journalism. Do you have any suggestions, either like for if a journalist, a lot of times as journalists we want to use our own sources, so we might be able to reference some of those, but we might want to contact actual people. So do you have any tips for how to use those anecdotes responsibly, or ways to find individual, like if people reach out to Vaccinate Your Family, are they able to connect with some of the individuals that were interviewed so that they can provide, or are there local organizations that people can go to if they want to find a local story? Basically, how can journalists get that sort of narrative voice in there, aside from just kind of referencing an online story?
I can take this first, and then if Bertha has any thoughts. I think I know, like, for example, people who have reached out to some of the people who've shared their story on Vaccinate Your Family for further, like, their own interview. So I think that can be one resource. I also know that, like, if you talk to people in your, like, community health workers can be a great resource for also connecting you to potential people in your community who are willing, to let you interview them. One thing I always think about when I'm thinking about storytelling is you want to make sure you're kind of capturing a variety of experiences when you can, right? Because the reason why, like, I think about this through, like, the angle of, like, those who are vaccine hesitant, right? The people who are vaccine hesitant for one reason may not be the reason somebody else is. In fact, it probably isn't, right? Everyone has different questions, everyone has different experiences, everyone has different concerns. So when I think about doing storytelling, I'm thinking about how can I kind of highlight some of those different pockets of experience so that I'm not just elevating one potential experience over others. But Bertha, do you have any other thoughts?
Yeah, I think the thing that comes to mind is that one alternative or one consideration is that the center and the focus doesn't always have to be the individual. The focus can be the public health lesson, right? The findings from the report, and you can build in stories of individuals around that isn't necessarily identifying of any one given person. And so if you just sort of change the focus, I think that's one strategy you can employ. And then the other thing I really want to encourage is that there are ways in which you can tell stories that doesn't necessarily rely also on words alone. So, visuals and video. People have different ways of learning, and so audio, music. I mean, ways in which you can sort of center the lesson and the story that you're trying to tell in ways that will be memorable is another consideration.
Great. A question from one of our attendees. Did the evidence review examine the capacity of acellular pertussis vaccines to prevent transmission of pertussis? Was that something that was addressed?
Emily, yeah.
Okay, yeah. So we were really focused for the scope of this review with looking at outcomes that kind of informed that initial CDC recommendation. So we did not consider any studies on population-wide transmission. Again, I think that would be a great kind of topic for future research, but not within the scope for this project.
What about within, I think they were thinking more in terms of within families, since cocooning was the previous strategy before the Tdap was recommended during pregnancy, like within a family.
Probably same answer in terms of looking at outcomes around safety and effectiveness versus transmission would be kind of a different body of literature.
Gotcha.
And maybe if I could just speak to that and say, when we reviewed 17,000 papers for the respiratory virus season, where there was just a lot more prevalence of disease, it was really hard to find studies on transmission. So outcomes of transmission are really, really hard. So as we were thinking about this review in the context of pregnancy, we knew we were going to have limited papers. And so we deprioritized it because we candidly didn't expect to find much.
Okay. I'll offer a little context to any attendees who are not familiar. One of the reasons, or the primary reason that the Tdap was recommended during pregnancy is that it was discovered in the early 2000s, mid 2000s, that the Tdap vaccine, which is made from an acellular pertussis component, which means that it's several proteins of the pertussis bacteria instead of the whole entire bacteria, which is used in the DTP that's given in a lot of other countries, that it wanes sooner. The antibodies, the protection from it wanes in about between 5 and 7 years. And so the problem was that what was happening is people would have multiple children. Their school age children would go to school. Their school age children would have gotten the Tdap, but the last time they had gotten it was when they were maybe 4 years old, and then they're now 9 or 10 years old, and they come home with pertussis, and the baby gets it. So that was one of the rationales behind offering that protection earlier. So that's just some context for those who may not be familiar with that history. Another question about sourcing. This is for Bertha and Elizabeth. If you mentioned trusted messengers, I don't know if you use that exact word, but that's what you talked about when you're pairing with faith leaders and influencer moms and such. If journalists want to try and include trusted messengers in their stories, if there's people that they want to quote, and first of all, is that a good idea? Should they be doing that? Should they be reaching out, even though that person's not a quote unquote expert? And where would they find those individuals? Like, what are some examples, maybe for either specific populations, or, how do they find out who the trusted messengers are for their particular community so that they can maybe go to those people? And what's a responsible way to include those in their stories?
Yeah, I think this is interesting. I think whether or not to include them depends on the kind of story you're writing, but I think one thing we often forget about is how much those connected people in real life impact the decisions people make. So if you look, at how people get information and how people think through their information and then how people make decisions, we would like to think it's always based on, evidence and information, but that's not true. Who's delivering it is just as important in some cases as what they're saying, like what is actually being said. So one way you can kind of figure out who is trusted in your community is to ask, go out into your community and see who is it that people go to when they have questions. Oftentimes, I live in Maine. A lot of times people go to the harbor master and find out the new news and or, they might go to the librarian or the post office person who's there all the time. So one of the things that we think about is how can we equip them to start having these kinds of conversations? Because, a lot of times we think that it's only a conversation that should happen in a clinician's office, but the reality is clinicians have such a small amount of time that if we can help equip these other trusted messengers to also be able to, navigate and talk about these things. Obviously, they should send out, like refer to experts when they don't have the answer for something. But we often can, that's a really important strategy that can often make a difference. So I think including them in stories, I think could be cool, but it would depend, I think, exactly on what the scope is and how you're framing it. Um, and we think about it primarily from how can we equip them so that they can, carry the information out.
Gotcha. This is a two-part question also about comms. What are the most common misconceptions of Tdap in pregnancy that you see? Because if journalists want to kind of use that pre-bunking strategy, what are some of the specific, inaccurate beliefs that they might come across? And related to that, I know when I've spoken with Karen Ernst over at Voices for Vaccines, she's spoken about how the word misinformation has now become there's a negative connotation attached to it. People sort of like get their hackles up when they hear that word. So what are some alternative words? I know I use misconceptions. Voices for Vaccines uses rumors. So if you could speak to whether or not it's okay to use that word, or if journalists should avoid it. And then again, like what kinds of misinformation, misconceptions, and rumors, whatever, are ones that they might want to be addressing in their stories.
I'm going to take the last part, and then Bertha, if you want to take the first half of that. I try not to use misinformation at all when I'm talking to the public in any way, because for a broad swath of the population, they now equate that with censorship and other things. So I use, and a lot of us within the Evidence Collective, we use false information, we use rumors, we use lies, and misconceptions is also a great one. So those are good ones that we also use. And Bertha, do you have thoughts on the other?
Yeah, I think one of the overwhelming ones is that some people want really quote unquote natural experiences during the pregnancy, and that a vaccine may introduce non-natural things, not realizing that, of course, as we discussed today, the vaccine provides that protection for the baby at a time when they're unable to fully protect themselves. And then questions about, well, why now and not why, not when the baby is born, and I can make a decision then, right? I'll make sure that the baby is protected. Like I can take on that responsibility. Confusion also, I think, around earlier you saw in the presentation DTaP versus Tdap. So confusion around that is a big thing. So clarifying what the two are and how they differ. And then there are also, I think, some cultural differences that we've observed as well. There are a lot of historic medical and scientific harms that have occurred in minoritized groups in particular. And so I think that some of the things that people believe about this and other vaccines is rooted in that. And then we can't forget, of course, some spirituality and or like religious underpinnings to reasons why people may believe information or have beliefs about this particular vaccine in particular. Some that may extend to the idea of fatality. Well, if it's meant to be, it's meant to be, right? And so then I'm going to make a decision just based on my trust in what I think is right at this time. Yeah, and then I think also, especially when we're writing in different languages, how we describe pertussis in particular is going to be a really sensitive issue also in terms of being accurate and how we describe what pertussis is. Because the word may be really unfamiliar to certain segments of the population. And so making sure that people understand what whooping cough is, what pertussis is, what are the symptoms that people might identify. And I think that's an educational moment as well.
I will.
I'm gonna highlight. Oh, go ahead. Go ahead.
The only thing I was going to add to that is when I scroll social media, I'm mostly seeing things related to adverse pregnancy outcomes. So people, saying it causes stillbirths or it causes congenital birth defects or the baby is more likely to have SIDS after they're born. Those tends to be like the most reoccurring and pervasive ones that I see very often in alignment with also the natural. Just keep it natural is the other big one, like Bertha said.
We're going to put into the comments, there's a series of tip sheets that was produced by Sciline, and one of those tip sheets addresses reporting on vaccines in religious and cultural communities. It's a little bit of a self-promotion because I wrote that article, but that might be helpful to people who are looking at that. I also wanted to point out something about the naturalistic fallacy. This is something I've used in individual personal communication, like one-on-one, but it's something journalists can do as well. A lot of times when that naturalistic fallacy comes up, the idea that, oh, I don't want to put something unnatural in my body, I help the person realize through a series of Socratic questions that the vaccine itself is protecting you through natural mechanisms with the natural body. The pieces of the bacteria are natural, that they are the pieces of the disease, and that you are harnessing your body's natural response to disease to do that. Now, as a journalist, you can't say that outright, but you can find a source who will say that for you, and that can kind of indirectly address that when it comes up. So that can be useful. We're getting right down to the wire on time here. So I'm going to ask each of the panelists to, let's see, we have each of the panelists to tell us what is something you would like to see more reporting about with vaccines or with this particular vaccine in coverage. Like if this is your wish list for journalists who are attending this, what would you like to see better coverage of or more coverage of? Not say better, but what would you like to see in the news? You're all thinking.
Well, I, as a public health person, gosh, this is just such a win for public health to have something like this available. And so I think a reminder that it wasn't always the case that we had this protection for babies would be a really important thing to share with people.
I think I would love to hear some stories about people who were hesitant and then got the vaccine and whatever vaccine it was and sort of felt empowered by the protection. Sort of the journey of people who were, trying to learn and understand, learned and understood the rationale for why, public health leaders, scientists, doctors were making these recommendations, and then to sort of walk that journey with people.
I'm going to piggyback off of that. I was that person. I was raised anti-science, anti-vaccine, and was vaccinated for the first time at 23. So I second that. I think hearing other stories like that is really important. But I also really wish that we could reframe some of the ways in which we talk about science as a tool of empowerment. One of the things that wellness industry does really well is it gives people a sense of empowerment, right? Take this pill and you're going to feel better. Do this thing and you're going to have an answer. And obviously we know it's false empowerment, but I think we can also frame, tools like vaccination and the knowledge that we now have as a way of for people to make empowered health decisions for themselves. And I think that can be an angle that can really complement some of the wellness narratives that are doing so well in this moment.
I'll just say, as someone who has worked on systematic reviews, it's exciting to have an opportunity like this to share the results of kind of a rigorous evidence review with a broader audience. We don't always have the opportunity to get our results sort of in front of an exposure of this type. So appreciate everyone kind of publicizing the efforts of Vaccine Integrity Project and getting the science out to a broader audience.
All right.
And maybe if I can chime in with one more, I will say there's a lot of scientific confusion right now with regard to some of what's going on with the Advisory Committee on Immunization Practices, which is now currently disbanded, no longer meeting. And I think some stories about the unity of the scientific recommendations, the evidence base, the work that the Vaccine Integrity Project is doing, as well as many of these other terrific organizations in collaboration with the medical societies, and that the medical societies are really actually speaking with a single unified voice in a way that unified voice used to be with the federal government, but is no longer.
That's one of the things I always emphasize when I'm talking is I don't refer to the CDC anymore. Instead, I refer to the American Academy of Pediatrics, the American College of Obstetricians and Gynecologists, the Society for Maternal Fetal Medicine, the American Medical Association, the National Foundation for Infectious Disease. There's a lot of different ones, but those are all fantastic organizations, and they've all been working really hard to provide sources to journalists. All right. Well, thank you everybody who turned in today. Thank you very much to all of our speakers. If you joined us late, we will send a recording out of this webinar to everyone, and it will be posted on YouTube within the next few days. A reminder that if there was a quote during this that you particularly liked and you want to use in something you're writing, that this was on the record, you are welcome to do so. And thank you again, everybody. Good luck on your stories.
Thank you.